So Dr. Winkelman is a professor of psychiatry at Harvard Medical School and a renowned clinician and researcher. He has particular expertise, as we all know, in restless leg syndrome. He's president of the International Restless Leg Syndrome Study Group. He's vice chair of the RLS-PLMD Clinical Practice Guidelines Task Force for the ASM. He's done,
Actually, now chair.
oh, chair.
I,
Thank you.
I graduated to chair. Yeah, I'm sorry.
Nope. Excellent. Thank you. And he is a renowned teacher. I think my favorite thing about him is that when I was a fellow, he taught me everything I know about restless leg syndrome and much, much more. And he's a dynamic and wonderful speaker. I don't think there's an intro I can give to do you justice, but basically, we're very lucky to have you here today to talk to us about actually something outside of restless legs, but a very engaging and interesting subject, I think, and very relevant. So
Thank you,
without
Sobel.
further ado.
So it is true, I've spent a lot of time working in restless leg syndrome, but have had just as many grants and maybe papers in insomnia, and see a lot of insomnia patients, which, as we all know, is really hard work. And so this topic is one that I think deserves attention because of how squishy most doctors in practice treat this question. Let's see if I can get the slides to move forward. Here's something that Yale requested me to put up. I don't know what it says. There are a lot of phone numbers that you can call and, get free something or other. And here are my potential conflicts of interest. I've highlighted the companies that I have worked with that have insomnia products. The others are this and that and the other thing. Okay. The reason I got interested in this is because of these questions. If you're treating patients with sleep disorders, I would imagine you get this question. Will I become addicted to this medication, or is this medication addictive? And I hope that at the end of this talk, you'll be able to answer that question in a meaningful way, or more meaningful than you would beforehand. Similarly, I do a lot of CME presentations, and the most common question I get from docs is, are these medications addictive? Or I don't want to prescribe those addictive medications. So there's a lot of ambiguity, let's say, in what this means. So what do these things, these words, that word mean? So we're going to break it down. And DSM has various answers, and here's Charles O'Brien, worked at Penn for many, many years, one of the leading experts in the United States on addiction and dependence. And he wrote, although an individual is addicted to benzodiazepines, hear about benzodiazepines, is usually physiologically dependent on the medication, patient may have a physical dependence without being addiction, which requires evidence of compulsive drug-seeking behavior, loss of control, as detailed in an old DSM. Among legitimate users of benzodiazepines, physical dependence can result from long-term regular use. According to physicians' instructions, this does not constitute addiction. Addiction on the right-hand side implies compulsive use, drug-seeking behavior, and a variety of other symptoms that I won't go into here if you pay attention to DSM-5. So already we're breaking down this idea of addiction versus dependence. And I'm going to do some brief historical perspectives written by guidelines. So the British Association for Psychopharmacology in 2010 said the question of long-term hypnotic treatment is one of the more controversial areas in psychopharmacology. Down below, the risks of physical dependence, and they said the hypnotic their use should be limited to periods of 2 to 3 weeks. Why? This view is not based on data demonstrating an unfavorable transition in the risk-benefit ratio after 2 to 3 weeks of treatment, but appears to have been because no substantive placebo-controlled trials of hypnotics had been carried out for longer than a few weeks, so that it was the absence of information rather than the presence of data. This was back in 2010. Here are the European guidelines for the diagnosis and treatment of insomnia, written by a variety of people. The first author, Dieter Riemann, an expert in insomnia, but parenthetically, PhD, who has never prescribed hypnotic agent in his 40 years of practice. Long-term treatment of insomnia with benzodiazepines or benzodiazepine receptor agonists is not generally recommended because of a lack of evidence and possible side effects and risks. Interestingly, strong recommendation, low quality of evidence. And they suggest that people should be withdrawn. And here is a table from that paper. And here are whatever 10 papers or so, published papers in the previous 15 years. Tolerance, negative, 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 negative. Not a single paper demonstrating tolerance to these agents. Abuse dependency, negative, 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 negative. No dose escalation, negative, negative, negative. Rebound. Many of them no, some of them questionable. So lack of evidence. It's interesting in the same paper. 6 years later, we get the same group of people. It must be borne in mind, however, that all hypnotics are symptomatic treatments, and insomnia symptoms typically return after discontinuation of these substances. Probably true. Concerning longer treatment, therefore, up to this point, the scientific evidence remains insufficient to give a general positive recommendation for any medication beyond 4 to 10, 12 weeks. I guess because it doesn't cure the problem. It's unclear to me what we do in medicine that cures any problems, other than if we're surgeons, maybe, where we do cure problems, or maybe psychoanalysts cure problems. But everyone else is managing chronic illness. We do, however, acknowledge that in some cases, after carefully weighing the advantages and disadvantages, longer treatment periods might be initiated. And then later in the paper, the evidence suggests that treatments in general should be limited to at most 4 weeks. And even then, with care, tolerance develops within days to weeks. It's confusing to me because that's not what the previous paper showed. Anyway. Then we see a very nice paper. Mike Satay wrote the clinical practice guideline through the American Academy of Sleep Medicine. Some studies have shown the long-term treatment with at least newer generation BZRA hypnotics can be safe and effective under properly controlled conditions. However, chronic use should be reserved for those individuals for whom CBT, blah, 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 and people should be appropriately screened for contraindications and maintain long-term gains and are followed regularly. Very reasonable guideline. So how do we answer when the patient says to you, are these medicines addictive, rather than just saying, oh, I'm sorry, our time is up. We'll get to that next time. Or when people come to me at the end of a talk and they say, are these medicines addictive, doctors? And there are many of them. And I say, what do you mean addictive? And you know what they do? At that point, they start kind of backing away. And I say, no. What do you mean addictive? And they say, addictive. You can't use the word in the definition. What is a chair? It's a chair. You have to use some other words. So what other words are we going to use to define addiction? And I would break it down into these 3 components: physiological dependence, psychological dependence, and misuse and abuse. And we'll think about these 3 components or processes to try to understand how to answer this question. So how do we define dependence? Now we're going to talk about each one of those 3 separate ones. How do we define dependence? Well, physiological dependence would be manifested by a reduced sedative response compared to placebo with repeated administration. Maybe we call this tolerance, right? Long-term trials, placebo-controlled. Does the drug continue to benefit the insomnia more than the placebo? Another option, thinking about physiological dependence, would be rebound insomnia or other withdrawal symptoms when you stop the active agent. Both these could be manifestations of physiological dependence. Pretty easy. Now we get to something that's much more difficult, psychological dependence. How do we assess that? It generally pertains, I'd say, to mental and emotional processes connected to the use of the drug for its anticipated effects over time. And we assess this through self-report. We ask people, kind of, but it's hard to assess psychological dependence. But we'll see some ways that maybe we can address this, but this is going to be the real weakness. And maybe this is what people mean by addiction. I'm not sure really what they mean, but this is certainly one component. So let's talk about physiological dependence. And I got a lot of slides here, and I'm going to move through them quickly because I don't have time to go into every single study. And you saw that there were at least 10 of them. So one of the reasons that people felt that tolerance developed, or physiological development, dependence developed, was based on this meta-analysis published 25 years ago now, showing that with longer-term studies using triazolam, I'm not sure that any of the young people know what triazolam is, halcyon, it was the number one hypnotic in the world before Ambien came out, that over long-term use, there was a loss of efficacy in terms of total sleep time, particularly, with just a few studies, actually. But it should be pointed out that those studies used 0.5 milligrams of triazolam, which is not a dose that we use ever at this point in time, even though the company did approve that, and it was probably a big mistake. And the Zopiclone studies here on the right, this is the parent drug of S-Zopiclone Lunesta, the non-isomer, used 7.5 milligrams, which would be 3.75 of Lunesta. So these are supratherapeutic doses. On the other hand, there are long-term trials, 6 to 12 months, of esopicolone, zolpidem, zolpidem, ramelteon, doxepin, suvorexant, lemborexant, and daridorexant, demonstrating no loss of efficacy. And I'm going to show you the data. And I'll send the PDF to whomever is interested, and then you can look at the individual studies. So the significant differences for these sleep endpoints persist for medications versus placebo throughout the trial periods. So here's a zolpidem study demonstrating continued benefit. You can see month 1, month 8, PSG, p-values. Sometimes things can get lost in the p-values. You know, if you have enough subjects, you're going to see a difference, but there's some diminution of benefit. We don't really see that here. Sleep efficiency stays about the same difference between drug and placebo over time. Subjective measures generally maintain their benefit over time. Zolpidem 10. However, if we look at this other zolpidem study, 12.5 controlled release, difference at week 4 and at week 24. And we see placebo in white and zolpidem 12.5 in black. And you can see that the difference here, and the absolute difference, is much larger at 4 weeks than it is at 24 weeks, even though statistical significance remains at all time points. And again, we see kind of a diminution of this benefit over time in pretty much everything, whether it be total sleep time, time to fall asleep, help me fall asleep. Now, some of this may be a ceiling effect, that it's pretty hard to get above certain numbers here. Most people aren't going to say 100 on anything. So that you have a ceiling effect. So this could complicate this. There are two long-term studies, 6-month studies with azopiclone. And this is what led the FDA to approve azopiclone without any limitation on the duration of use. This was the first hypnotic that was approved without the 4-week limitation, four-week limitation. And they just said, you can use it. And you can see the lines are basically parallel from month 1 to month 6. Total sleep time, wake after sleep onset, sleep latency. This difference here. Second 6-month study takes nerve to do a study that upends what everyone thought about these medications and then replicate it. For those researchers out there, I would encourage you, if you get a groundbreaking result in some study, don't try to replicate it. I've done it myself. I replicated it the first time, got really cocky, tried to replicate it again, couldn't. So don't be silly. Anyway, and here you see 6-month trials, and you see placebo up here and drug in here in terms of sleep latency here and WASO here, and really maintained differences across the 6 months of trial. Ramelteon, and you can see pretty much parallel lines in Ramelteon and placebo. Doxepin, same thing, continued efficacy up to 85 nights here. Comparing this and this, at least at the 3 milligram dose. And this is wake after sleep onset. Here's Suvorexant. This was published, gosh, just seems like a few days ago, but it was in Lancet Neurology almost 9 years ago. And here's 12-month data on the right and continued benefit in subjective total sleep time, subjective time to sleep onset, wake after sleep onset. You see there is a change in the p-value from 0.0003 to 0.0048. The difference, though, is really pretty much the same, -9, -7, -10, -10. So some of that is the loss of subjects over time, so reduced power. Here's a daridorexant study. Little bit complicated, 12 weeks. They had 3, it was 2 doses of daridorexant and placebo. And then they re-randomized most of the placebo people to either continued placebo or to low-dose daridorexant. And you can see here at 40 weeks, you're still getting the significant difference of the orexin antagonist versus placebo. Maybe it's not quite as pronounced as it was at 4 weeks, but continued benefit over that time. And a very complicated study. Tom Roth and Tim Rears did a series of really cool studies, very clever, very, very clever studies. And they had 12 months where people were using placebo or zolpidem capsules that were color-coded. They didn't know what the color was, and they could take a certain number of them. And they asked them, trying to remember the details here, When given an opportunity to choose the number of capsules taken nightly, the nightly self-administered dose of the zolpidem group was comparable to the placebo group, but most importantly, did not differ over the 12 months. They had the choice to take more, but they did not. Whereas the placebo dose does change over time. People wanting to take more to get more benefit. So this is a choice rather than the previous studies. This is a choice study where people were given the option of how many pills to take. So most of the data, and we saw this in the review paper from the Europeans, does not suggest that there's any loss of efficacy over at least 6 to 12 months in most of these in the kinds of patients who are enrolled in these trials, which is two important caveats. One, our patients may be using them for more than 6 to 12 months. And two, the people in the trials may not be the people that we're seeing in clinic. Rebound insomnia is evidence of physiological dependence. So there's two ways of looking at rebound insomnia. One way is to look at group means. And rebound insomnia is defined as a worsening of sleep compared to baseline, not compared to treatment, because they're not getting treated anymore, obviously, but they have worse sleep after you stop the medicine than they did when they started the study. So here they are at baseline. Here they are at the end of 12 months. This is with suvorexant. And here they are on the first 8 days post stopping the medicine when placed on placebo, blinded. And you can see sleep does deteriorate. And those people move from suvorexant to placebo, but is nowhere near as bad as it was at baseline. And here's time to sleep onset, same thing. Baseline, end of 12 months. And a loss of efficacy rather than rebound. Another way to assess rebound insomnia is to ask how many people, what percentage of the population who was in the trial had a worsening of sleep, not using means, but using a within subject design, people as their own control. And here we do see some evidence. This is on night 1. Here's placebo, and let's look at sleep latency. And when placebo went to placebo, there was very little rebound insomnia. Low dose Zolpidem, 5 milligrams, no difference. 10 milligrams of Zolpidem, no difference. 20 milligrams of Zolpidem, really not much difference. On the other hand, Zolpidem 10 milligrams, we had almost 25% of people had a worsening of sleep on that first night compared to their baseline. So I think we can get something from this that it's quite possible, at least with Zolpidem 10, on the first night of placebo discontinuation, which is not something we ever do, obviously, in clinic, but even with placebo discontinuation, people can have a worsening of sleep compared to baseline on night 1. And here's from that Satay article in the Journal of Clinical Sleep Medicine, the clinical practice guideline. And rather than going through all the studies, I thought I'd just put this there. Some studies found no evidence of rebound. Other investigated reported evidence of rebound, limited primarily to night 1. Suvorexant may have the proportions of patients with rebound insomnia were numerically greater in people switched to placebo from Suvo. For Meltion, no evidence of rebound. So certainly something we want to mention to patients. If you're taking this medicine for a year at a certain dose, and you stop it abruptly, even if you were given a pill so that the psychological effects are not present, your sleep will certainly get worse compared to when you were using it. This doesn't cure the problem, and I say that to every patient. This does not cure your problem. I don't know what treatment we offer in sleep medicine that cures people's problem. Maybe the surgeons, maybe they cut something out and it cures the problem, but everything else, we're managing chronic illness like the rest of medicine. There are some studies, again, from this old meta-analysis that shows rebound insomnia, again, at doses that we don't use in practice. And in some of these trials, they didn't give them placebo. They had them take it for 4 weeks, 8 weeks, 12 weeks, and then just stopped medicines. What is the problem there with that approach? It confounds physiological and psychological dependence, right? They weren't sleeping. They put something in their mouth. Now they are sleeping. And now they don't get to put anything in their mouth. And what happens? They get anxious. So the psychological dependence and physiological dependence, if you don't give placebo in these trials, you don't know really what's going on. Here's that same Rears article. This is a percentage of people whose sleep efficiency was worse than screening on the first discontinuation night at month 1, 4, and 12. And you can see at 12 months, whoa, I didn't do that. Who did that? At 12 months, you can see there was maybe 10% more people had rebound than placebo. So are there withdrawal symptoms aside from rebound insomnia with hypnotics? Most studies, clinical trials didn't assess those, but the studies that did assess them, and the ones I mentioned here, did not find withdrawal symptoms other than looking for rebound insomnia, which may or may not have been present. But in terms of other withdrawal symptoms at doses that are FDA approved, generally withdrawal symptoms are not seen. If people are taking super high doses of benzodiazepines for long periods of time, they could have withdrawal. Will they have seizures, which is kind of everybody's anxiety? High doses, long periods of time, maybe. Okay, now we get to psychological dependence. This is the tough one. As a kind of a numbers guy, I like to have numbers. And how do you measure psychological dependence? Well, the opposite of psychological dependence is an expectation of benefit, which we would call placebo. We assume placebo works. The doctor prescribed it. I'm going to take it. It's got a little pill bottle. It's got all kinds of warnings. It must do something. And so expectations of benefit are present throughout medicine and very common in insomnia. So it should not be surprising that the expectation of loss of benefit is natural when discontinuing treatment. Does that make sense? Those of you who are still there, I see a lot of faces. Thank you very much. Just going to look at the faces for a second. Hi, Robert. Beth, my goodness, I haven't seen you in a long time. And our current fellows. And then a number of people who want to remain anonymous. That's unfortunate. I only wish for you, when you are giving Zoom talks, that the people who are listening to you will show their faces. Okay, psychological dependence. There's an interesting scale that is being used nowadays called the Severity of Dependence Scale, the SDS. So let's just go through this super quick. Let's say it's Ambien. Did you think your use of Ambien was out of control? You're regular patient. They'd probably say no. You can see the scoring down here. Did the prospect of missing a dose make you anxious or worried? What do you think your patients would say? My patients would say, probably often. You know, I know if they're running out of medicines and it's a weekend, they're paging me. So they must be anxious or worried. So I'm going to give them a 2. Did you worry about your use of Ambien? I don't know. Maybe some people would say sometimes. They've got a 3. Did you wish you could stop? Most patients would probably say, yeah, I wish I didn't have this problem. So that gives them up to a 5. How difficult would you find it to stop or go without your Ambien? Here is a separate scoring system. I'd say many people would say very difficult. That gives them a 7. So according to the severity of dependence scale, these people taking Ambien are dependent on this drug. This is psychological dependence. They don't really make that clear. Probably should be called the severity of psychological dependence, SEDS, to make that much more clear for people who are using it, because otherwise it can be used inappropriately. And it gets to this question that I think we need to ask when people are using these medicines. And we'll get to this later in abuse. Are they using it for relief of symptoms or for reward, some kind of other benefit? And I think that that's an important distinction. And I got that from a paper that Kate McHugh, who's at McLean here in Boston, wrote. We'll see some data from her later. Here's a neat study. This was done again by Tom Roth and Tim Rears at Henry Ford in Detroit. So they had people go through all of these. They're people with normal sleep and they're people with insomnia. I won't go into all the details, but they had them do these 3, 1, 2, 8, 9-day periods in random order. In each of them, they had an adaptation night and then a baseline night without a pill. And then this is how the group's different. In one group, they got 6 nights of triazolam high dose. In the other group, they got 6 nights of triazolam in a descending dose, 0.5, 0.25, 0.25, 0.25, 0.125, 0.125, none. And then they finished with 1 no pill at the end. So there were people who were getting the triazolam in different doses. And then this group of insomniacs and normals, some of them got 6 nights of placebo. They never got any drug. So 2/3 of the time in these different arms, they got triazolam. 1/3 of the time they got placebo. And what they found is a consistent but unexpected finding in the rebound insomnia analyses was the presence of a worsening of sleep upon pill discontinuation, regardless of the type of pill. Even when these people, normal sleepers, people with insomnia, got placebo for 6 nights, when they didn't get the pill on the 7th night, their sleep deteriorated. The mind is powerful, eh? So this is sometimes called pseudo withdrawal. I didn't get my pill. I'm not going to sleep. Or maybe it's my pharmacy gave me a different generic. It's not the white oblong pill. It's a round blue pill. Does that work as well as the white oblong pill of whatever I was taking? Okay, psychological. That's really all I have to say about psychological dependence, other than I think that this is powerful. And I think it's particularly powerful in people with insomnia. Is that bad? I don't know. Psychological dependence is something that we all have. I am dependent on my wife. I'm dependent on my friends. I'm dependent on my kids. I'm dependent on my home. Dependence is something that has been good to us that we would like to continue having. But I think that when we talk to patients, we need to talk not only about the physiological dependence, but we need to say to them, how likely are you to be somebody who's going to be psychologically dependent? So it's going to be difficult for you to stop this. And CBT obviously is an important method of addressing this, but that's another story. So now let's talk about the third component of addiction. And I usually make a joke when patients say, am I going to be addicted to this? I say, do I think that you're going to be like going to Coolidge Corner and trying to score some drugs and shoot up? No, I don't. And they laugh. And, but I think that this is something that people are concerned about, abuse in this context. And it has many definitions. Most commonly, we say that it's used for non-medical purposes or excess use for the original intended symptom. Excess use for the original intended symptom. DSM-5 has a very specific definition for substance use disorders. It's when the use causes clinically and functionally significant impairment. That would be Ambien use disorder or suvorexant use disorder, right? So if we want to use psychiatric definitions. There are a variety of ways that abuse has been assessed in the literature. You can look at animals and see whether they will self-administer the medication, particularly primates. You can, and this is the FDA uses the second method, is they take people with a history of substance use and they give them in varying orders drug that they're investigating at different doses. They give them placebo, and then they give them some active comparator to make sure that that demonstrates some abuse or not abuse here. And what they do is then they give it to them, and then every 15 minutes or every hour, whatever, they say, how much do you like this feeling? Scale of 1 to 5. How much do you like it? So we'll see some data on that. Then there's these long-term choice studies that I showed before, where you look and see whether people are dose escalating. And then we have epidemiologic data, where they go out into the community and ask people about their use of medications. Roland Griffiths, who was at Johns Hopkins, who unfortunately just died, was very interested in abuse of various medications, and he combined information from animal data, liking studies, et cetera, and kind of ranked, this was 20 years ago, ranked various things. And the barbiturates were at the top of we want to look at the black, we're at the top of the abuse liability. Towards the bottom, trazodone had none, clozapam not a lot, diphenhydramine not a ton, some of the benzos and non-benzos not that much. And he combined it. If it's an interesting study, he looked at animal drug self-administration, human liking, and actual abuse. And if you Google Benadryl abuse, you will find people abusing it. People are injecting melatonin. You find stuff on abusive amitriptyline, doxepin. No matter what it is you look, somebody is, God bless them, using it to try to get some feeling that they like. So let's look at the liking studies, which are really interesting and not always consistent. So here's the drug liking. I don't know what the whole scale is, might be up to 5. And you can see, and here's is 0 to 100. And these are people with histories of substance use disorder. Gave them placebo. They said, don't really like it a lot. Triazolam, halcyon, dose-related, increased in liking. Zaloplan at doses that are above prescribed. This is Sonata. People liked that as well. Here's another study. Placebo, now low-dose triazolam, instead of being up here, is down here. But higher dose triazolam, people liked. Zolpidem, 15 milligrams. Didn't seem to be very well liked by people. Maybe this study somehow is missing some sensitivity. But to get 30 and 45 milligrams, people are saying, I'll have another, please. Trazodone, interestingly, in this study, seems to have more liking, wired standard error, than both zolpidem and triazolam. And as you increase the dose, people like it less. Maybe side effects start to bother people. Suvorexant, here's placebo, 0 to 100 scale. Suvorexant, 50. Let's just start with zolpidem 15, which is at about 75. You get to zolpidem 30, and you get to about 80. Interestingly, Suvo at 40 milligrams. Now, this is double the maximum dose that the FDA allows, has about equal liking to zolpidem at 15. Daridorexant. First, to orient you, here's 0 to 100 visual analog scale. This is placebo, out to 24 hours. Okay, placebo. Daridorexant here at 50 milligrams, which is the highest, it's prescribed in 25 and 50. Daridorexant people seem to like. And they seem to like it almost as much as 30 milligrams of zolpidem. Definitely not as much, but surprisingly, daridorexant is high on drug liking, and suvorexant at supra prescribed doses seems to be liked as well. So I'm going to finish now with some epidemiologic studies. These are data from the National Survey on Drug Use and Health. They go around the United States and they just go to people's houses and they ask them about use of various medications. And this study is not particularly helpful because it lumps benzos used for anxiety and agents used for sleep. But if we look at the percentage of people in the last year who said that they misused the drug, which is use the drug in any way a doctor did not direct you to use it, including using it without a prescription, using it in greater amounts, more often, or longer than you were told to take it. So misuse very widely. What we see here is that this is age-related. Young people, I'm always suspicious of those young people. Young people seem to have relatively high rates of misuse, 30%, 40%, 24%. Then once you start to get to middle age, 12%, 8%, and people over the age of 65, 4%. So much less misuse in older people. So it's age related. This is combining benzos used for anxiety probably and hypnotic medicines. And let's just skip that. Let's go to this recent paper that just came out from McLean. And this is really, I think, interesting. Why are people misusing medicines? And so they asked the people, again, this is a National Survey on Drug Use and Health. So they went to those people who were misusing, in this case, Z drugs. So zolpidem, esopicolone, zaloplan. They went to them and said, why? What are your recent motives? And they could check off a number of options. And they did the same thing for benzodiazepines. So why are people misusing benzodiazepines? Number one, to relax. Number two, to sleep. Number three, for emotions. Number four, to get high. Why are people misusing Z drugs? Really, almost the only reason is to sleep. So again, we need to distinguish relief from reward. It looks like benzodiazepines are commonly used for reward. Getting high is relaxing to treat anxiety disorders. Maybe that's relief, but people misusing Z drugs to sleep for relief, presumably, of their insomnia. So this is, as I said, a work in progress. My thinking is developing on this. I submitted a discussion group to APSS with 6 or 7 other folks with a variety of different perspectives to talk about this subject, to try to see if we can get some agreed upon way to address this question of whether hypnotics are addictive or not. Can we agree on the terms that we would use by which we would assess that question? And how do we talk to patients about risk? Because obviously what we do in medicine always is risks, benefits, risks, benefits. And so if we don't know what we're talking about when they ask us this question, we can't agree on what the components are. How could we even talk to them about risk? But so far, my thinking, and I'd be interested in others' thoughts. So the majority of studies don't demonstrate loss of efficacy for the hypnotics at FDA-approved doses, even for periods up to 1 year. High doses may be an important moderator of loss of efficacy. However, many patients in clinical settings will use these medications for much longer, and our patients may be different than the ones that are in the clinical trial. What does that lead us to do? It leads us to make sure that we evaluate our patients, make an individualized risk-benefit assessment. Rebound insomnia can occur with hypnotics, though it's often time-limited, maybe a small effect. High doses may be a predictor. Withdrawal symptoms are unusual. My last slide. Those with insomnia appear to be vulnerable to psychological dependence on hypnotic agents. There are very few studies of this issue, which is central to concerns about the use of such medications over both the short and long term, and to attempts to de-prescribe, which is to reduce hypnotics. And clearly addressing any psychological dependence is a central feature, should be, of your discussions with them and of cognitive behavioral therapy for insomnia. Why do people develop psychological dependence? They might have feelings of helplessness about their condition. They may just have had the medicine work really well. They may have had then concerns about reemergence of insomnia and all of the exaggerated catastrophic thoughts that they had beforehand. They may have generalized anxiety. Such psychological dependence has not been formally assessed in those people with comorbid substance abuse, anxiety, or mood disorders, which may increase the vulnerability to such psychological dependence. Abuse, defined as liking in those with substance abuse history, is present for many hypnotics, generally at doses, though, above FDA approved. In one dose escalation trial, where people were blinded as to what they were taking, dose escalation was not seen. But misuse and abuse are observed in the general population at low rates, but may be predicted by age. I'm going to stop sharing. I'm going to see if there's anything in the chat that's relevant. No, all kinds of stuff about CME credits and other free things that you can get. Free food, some kind of swag. Questions. Sogol, are you handling this part of
I
things?
can, but I'm also happy to have you handle the questions if you would like. I have a question to start.
Yeah.
Well, first of all, thank you. That's a fantastic talk, and I always learn a lot from when you speak. Um, one question I have is I frequently get referrals from neurology and primary care that a patient has been on, say, Klonopin or another hypnotic for years for their insomnia, and now they're having memory loss, or they're concerned about their risk of falls, and they want me to wean them off of this medication. What is your approach in this situation in terms of, sometimes I have patients who are physiologically dependent. When I talk to them, it turns out maybe this medication isn't doing so much anymore, but if they stop it, they're convinced they will not sleep again. Other times I have patients who say this is still working very well for me and I don't want to stop it. I don't know if you have suggestions on how to approach that.
Sure. Complicated question. First, Klonopin is not a hypnotic and should not be used as
Benzodiazepine. You're right.
should
It's a
not be used as a
benzodiazepine
hypnotic.
that
You heard
also
me
isn't
say
good
that
for
many times.
insomnia. Yes, I have. I'm sorry. And it's also, I don't think should be used for insomnia because of its very long half-life, unless they
Exactly.
have
That's
a
what I mean.
comorbid anxiety disorder. But it
Okay.
often is. So I should say
Yes.
they come to me on Klonopin
Yes.
or on, say, Ambien or Azopiclone or
Yep.
Lunesta. And
Gotcha. So they are physiologically dependent, you said. You think they might be because it's no longer working. Not clear to me if it's no longer working because they're physiologically dependent or because their insomnia got worse. Without a placebo arm, you're frozen. Oh, you're unfrozen. Without a placebo arm, we can't tell if loss of efficacy is due to a worsening of disease or due to loss of efficacy of the medicine. Nevertheless, and the questions of falls, this was all just about addiction. This was as one component of risk. Clearly, falls, memory disturbance, other things, there are other side effects and risks of these medications which need to be taken into account. So I commonly get the referral from primary care. I've got a new primary care doctor. My old primary care doctor had been prescribing my 10 milligrams of Ambien for the last 10 years. And it's been working, but my new primary care doctor says, I don't prescribe those medicines. Period. I don't believe in them, like it was a religion or something. I don't prescribe those medicines. So that doctor has basically eliminated risk benefit from their practice of medicine in this area because all risk is greater than any benefit if they don't prescribe them. They should not be seeing patients with insomnia because they're not practicing medicine. But I commonly get them. I don't prescribe them, and they send them to me. Now, what do? They're basically dumping them in my lap. And so if they continue to have benefit and they're not having side effects, at least for the first period of time, I'm going to continue the medicine. Then I'm going to refer them to CBTI. And I'm going to say to them, you're not having any side effects now, but many of these medicines are associated with, particularly I worry about falls. I think that the dementia story with hypnotics doesn't really make sense.
So if they come
Because
and they've developed memory loss, will you say it's not clear that it's from this medication, or do so you don't think we should just wean when people start having memory loss because there could be other factors causing it, or?
no. It certainly they can in the short term produce memory loss. Whether they promote dementia is another story. And so somebody who has MCI, I'm going to try to remove them from the benzodiazepine receptor agonist for sure. And I'll say to them, this could be exagerous, as I would probably with gabapentin and pregabalin,
That was
and,
my other
and
question, because I worry about that with gabapentin too. And should
yeah,
patients on gabapentin be weaned when they start developing memory loss? Okay.
because now you wean them, they do CBTI, maybe it works, but if it doesn't work, now they're not sleeping. How does that work for their memory? It makes you feel better because you're not giving them this drug anymore. You've washed your hands of it, but it's not clear to me that that is a benefit to them, both in terms of their memory disturbance as well as their quality of life. So this is a conversation that you have with patients individually, but certainly if they're having memory disturbance, I will encourage them to try to taper or switch classes. If they're on a long acting benzo, maybe switch them to shorter. If they're on a short to intermediate acting benzodiazepine, switch them to another class. We got a lot of other agents that help with sleep
Right.
that don't seem to interfere acutely with memory consolidation. And the same thing would be true for people with significant neuropathy, who now are getting up in the middle of the night to go to the bathroom in the dark, and they're on something that's going to make them unstable, whether it be an alpha 2 delta agent, gabapentin, pregabalin, or a benzodiazepine receptor agonist. I'm going to try to switch them to something else. But it's a little off the topic of addiction, dependence, abuse. It's more of a general risk benefit kind of conversation, but I appreciate it's a really common and important issue.
And then if no one has other questions, I have more.
I don't quite understand. This must have been so clear to everybody, or so irrelevant to your practices, or so boring that it didn't stimulate any thoughts in anybody. Does anybody get this question from their patients about addiction? Is this something that you worry about with your patients? Are there other components of this question about addiction that you think I missed? I give these talks so that I can
I
better
have,
understand the issue.
I have a question.
Thank you, Stuart.
In trying to discontinue a medication, understanding the risk of the psychological dependence, is there a possible use of a placebo um, during that period of time? And would it help a patient to know who says, well, when you finally stop the placebo and they complain, say, do you know for the last week you haven't been on any effective medicine and you were not having any problem?
Well, we can't write on our prescription pad placebo 5 milligrams. But we can give them melatonin, valerian root, magnesium supplements. I had a patient a number of years ago say to me, you know, doc, I had terrible, terrible insomnia until I started eating 5 black olives shortly before I went to bed. And they said, and my insomnia went away. And I said, you know, I've seen that before. You should always walk with placebo on your side. So I think it's reasonable as you are deep prescribing to substitute something that they can put in their mouth that they have some faith, and you can say, you know, this really works for some people, whatever it might be. I think that that's a completely reasonable approach. I think they do need something to address that anxiety, that what I call insomnia phobia, that develops with long-term insomnia and certainly develops as they are trying to deprescribe or stop these medications. But go for it. I think it makes, try the black olives.
On a certain parallel question about CBT, how much of CBT is really helping with the psychological aspect?
I think that there are two main components. There's the sleep deprivation, which, you know, a number of studies have shown that sleep restriction therapy is probably the core component and also the most difficult component for people to adhere to. But that probably has a lot of pop. It has a lot of influence and efficacy. But the other part, I think, is the addressing the psychological dependence and talking to people about the anxiety that gets aroused when they're no longer using this, having this bed partner, if you will, that they've had for who knows how long. You know, many people are dependent. I sleep a lot better when my spouse or partner's there, or my dog is on the bed. Just something there. And so I think we have to address both those psychological components, but also increase drive, both.
If someone is physiologically dependent, and I say that based on your talk, they are not necessarily benefiting from the medication anymore, let's say, but they're not having side effects either, let's say, and psychologically dependent, should they be weaned off the medication just by virtue of that physiologic, that they're not benefiting from it anymore per se?
Again, it's hard to know if the lack of benefit is due to the loss of efficacy of the medicine or a worsening of the underlying disease. Somebody has hypertension and you're giving them losartan, and they've been on that stable dose for 5 or 10 years. Now their blood pressure seems to be higher. Have they developed tolerance to the losartan, or did their hypertension worsen? So,
And so you feel
it's
comfortable
hard to
adding
know.
a second agent at that point, or do you prefer to wean and then add?
No, I mean, it depends what the dose is. If they're kind of at the max dose, I usually add and then subtract.
Oh,
That's my general approach to if I want to stop something. I'm rather than weaning them and having them be on nothing for a while. And, you know, I just want you to suffer now for the next, month while you're on nothing. And then, so I will usually add and subtract.
If I can make a quick point, John. So I have about maybe a dozen patients using a combination of an orexin antagonist and the Z drug with really great benefit, which was not obtainable by either of them. So although, typically combinations are not evaluated and they are, I guess, verboten by insurance and all that. Combinations do have a role.
Yeah.
So overlap is not a problem.
All what?
Oh, so overlap, I don't see as a problem at all.
No, I don't see it as a problem either. And, hypertension, they got bad hypertension. They're on 3 antihypertensives.
Right.
It's like we're doctoring here. We're trying to minimize symptoms and the long-term effects of those symptoms in terms of risk for other things. And we're balancing the benefits and the side effects on an individual basis in collaboration with our patients. In the end, they make the decision. But I agree. Sometimes you got to do what you got to do. We see difficult patients.
Yep.
They don't come to you and me, Robert, because things have worked out with their other doctors in their sleep. I have a question here from Carl Anderson. Based on what you've talked about, do you have a preferred medication to prescribe patients with insomnia now in drug-naive patients? Do you tend to set expectations you're going to prescribe them for the short period? What do I prescribe? We got a lot of choices. It's a good time to be a sleep doctor, right? We got a lot of choices. So I would say it's a complicated question, which involves obviously a lot of comorbidities. So I don't have a single drug that I go to. If they've had insomnia for a very long time, my sense is it's not going away anytime soon. And therefore, I'm going to be initiating a medication that I would be happiest having them on it for a very long time. They've had it for a long time. It's probably not going to go away. They're probably going to need something long-term. So whatever that might be, whether it's an orexin antagonist, whether it's trazodone, whether it's doxepin, those are probably in my top drawer. But then if they are not working, I'm going to go to a benzodiazepine receptor agonist. I do see a lot of mirtazapine used, particularly in older people. This seems, I don't know if all of you have this experience, someone over the age of 65, first thing, primary care, everybody does, start them on mirtazapine, which has some benefit because it helps with depression, and it helps with sleep, and you get a twofer there. However, we always need to remember that the main side effect of mirtazapine is weight gain. And I think we kind of assume you're old. It doesn't matter to you if you gain 10 or 15 pounds. Younger people, of course, they don't want to gain 10 or 15 pounds. But I think that this is a mistake. And I see the people who've gained the 10 or 15 pounds. And just because they're 75 doesn't mean that they don't care about how they look. So that has to be mentioned. But I would say those would be the medicines I'd try first line. Do I set expectations about how long they're going to be on it? I'm trying to send them to CBTI. If CBTI, and I usually prescribe after CBTI fails, if it fails. And I'll say to them, you've had this insomnia for 15 years. I'm not sure this is going away very quickly. It might, and I'd like to prescribe this medicine and then see if we can taper it in a few months. But that may not be possible. I mean, how do you feel about that? Now, if they have acute insomnia, their dog just died and they're bereft, this is probably going to be short-term treatment. Under those conditions, I'm going to give them the good stuff. What do you want? If you find out that you've got, or somebody in your family has a life-threatening illness, do you want melatonin? Do you want trazodone? What do you want? I know what I want. I want the good stuff under those conditions. And so that's really what I should be offering my patients, as long as they're appropriate and don't have histories that would concern me about misuse. So its golden rule is very helpful there. Adrian asks, since CBTI is not always available in medical practice, what are your thoughts regarding digital CBTI in the weaning of hypnotics? I think they're certainly worth a try. You have to be disciplined to use digital CBTI. Adherence rates are really terrible with digital CBTI. You know, people like people. We're funny animals that way, and that people just talking to people really seems to help. And maybe I'm disclosing my psychiatric past, but so working with an individual face to face, I think, is valuable. But for the more disciplined individuals, I think digital CBTI can be helpful. You know, the data is very strong for the people who use it. The problem now is that it's hard to access digital CBTI. Somrist doesn't exist anymore. Maybe we'll have Son of Somrist at some point, but they kind of flubbed the release of it, I think. And there's a VA app for digital CBTI, not as user friendly as Sleepio or Shut Eye, but Sogol says she's testing a new digital CBTI app. Everybody's testing a new digital CBTI app, and everybody's testing a new one of these. You know, people realize that we need to do something better than we're doing. And Sogol, I hope yours is good and easy to use and easy for us to get access to and free for all of our patients.
It'll
Or at least
be
covered by
cheap,
insurance.
but not free. I think they're planning to sell it for $30.
Oh, hell yeah. For the
It's a
whole thing.
35-day app, 10 minutes a night. It's easy to use. I'm doing it myself,
Yeah.
but we just started recruitment.
That's great. We need more accessible digital CBTI. And maybe even some digital CBTI has some backup human access. The AI on this is kind of complicated. When to tell people to reduce, oh my God, Beth, to when to reduce time in bed, when to start increasing time in bed. So we certainly need them because if you use it, it works oftentimes. Go to sleep through the Cleveland Clinic. I wasn't aware of that. Thanks, Sogol. Why don't we finish? Beth, why don't you tell us the name of that baby?
Hi, this is Brooke.
Oh my goodness.
In October. She is
That is a Gerber baby.
Old. Thanks. She enjoyed the talk, the latter half.
I hope she's sleeping okay.
She's sleeping not bad. Not bad.
Good. Good to see you.
Thanks so much. Good to see you.
Okay.
Thank
nice
you
to see
so
everybody.
much. Thank you
You're
so
welcome.
much. We ran, sorry,
for
15
inviting
minutes
me,
over.
Sogol.
I didn't even notice. Thank you for speaking. We appreciate it.
You're very welcome. And if this happens at APSS, come to the discussion group because it should be interesting.
Awesome. Thank you.
Bye.
Bye.